Hi everybody, today we're going to be talking about PTSD and other stress-related disorders. PTSD is a very debilitating disorder, and when we think about it, we think most often of our veteran population, although we see it among those who've experienced sexual assault and other sorts of traumas, and we'll talk about that momentarily. I don't know if you've ever seen the show Homeland, but especially in the first season, when he returns back after being held captive for many, many years, he does a very accurate representation of what it would like to be living with somebody who has PTSD. So just to give you a little bit of a background, PTSD kind of originated from observations of veterans of war when they came back after kind of the First and Second World War. You heard things such as shell shock and battle fatigue, because kind of historically we didn't talk too much about emotions back in the day. A lot of people described how the men came back from war changed. Many of them probably suffered from PTSD, but there was no particular name for it at the time, and it was just kind of accepted as that was one of the byproducts of being in such a war. So initially, when they had the diagnosis of PTSD, you had to be directly exposed to the event outside a normal circumstance. But now you can hear about events or watch them on television and still have PTSD. I recently saw an article whereby a girl, or a woman now, she was a girl at the time, but she was in a school that was close to the World Trade Center, and while she did not directly witness what had happened on 9/11, she was close enough that there was fallout from it, and she to this day reports that she's been experiencing symptoms of PTSD and has been diagnosed with PTSD even though she did not directly experience that trauma. So prior to the DSM-5, PTSD was classified under the anxiety disorders, and that's how I learned it when I started studying psychology back in the day. But now with more research, and that's kind of, we talked about the development of the DSM-5 and the research groups and looking at the most up-to-date kind of findings with clinical, biochemical, and fMRI data, investigators have concluded that PTSD actually is not a fear and anxiety-based disorder, so similar to what we were discussing with OCD. Rather, the disorder is better classified with other disorders that arise in response to traumatic events and are characterized by symptoms of avoidance or negative alterations of mood, but not fear. So while there may be kind of this terror or fear associated with the initial event, they've now classified it separately. So they're seeing that there are different brainwave patterns, there are different biochemical reactions than the anxiety disorders we talked about, like GAD and social anxiety disorder. So PTSD occurs after a severe and extraordinary stressor that involves actual or threatened death, serious injury, or sexual violence. Some examples can be a massive fire, a hurricane, the Holocaust, rape, mugging, military combat, or terrorist bombing. So there's generally a fear that you could die, and then that fear kind of gets relived, and we'll go through the criteria. So in the months following being exposed to this stressor, usually, when we think of PTSD, we think of a one-time stressor, but with the cases of like childhood sexual abuse, there's not one particular stressor that causes the PTSD, but a series of events that have traumatized the individual. Similarly with military combat, while there may be more salient, things that people see, it's kind of sometimes the culmination of everything that's witnessed. So in the months following the stressor, the patients waver between two stages of PTSD. Avoidance of the event, so they do everything they can to avoid thinking of the event because it's so incredibly painful, and then re-experiencing, called kind of intrusion. So these are thoughts that they don't necessarily want to have, but they often come back in flashbacks, nightmares, or thoughts we can't get rid of. Often the avoidance or denial comes first with the psychic numbing, kind of the flat emotional reaction dominating, and this is somewhat normative, and so you shouldn't necessarily feel like somebody who has been exposed to a stressor should be like crying or very upset. This is our body's way of handling things that we cannot emotionally deal with at the time. The difference therein lies that people who go on to experience PTSD often never have that emotional experience, which is required for processing of kind of grief or traumatic events. And therefore, the PTSD can arise because there's kind of this constant push to keep it out of the conscious mind, and therefore it kind of pops its head out and rears its ugly head when you don't want it to, and hence you have these experiences. So what was really interesting is around the time of 9/11, and what was really popular was this thing called critical incident stress debriefing. So when something like this happened, like a terrorist attack or a workplace shooting, what they would do is these critical incident stress debriefing teams would come in, and they would have everybody basically locked down, and they would have to process the events because they felt that this would prevent PTSD. And so, people who just, saw their colleagues potentially getting shot, or who just witnessed something horrible happening, now had to stay in a room, and they had to kind of process what was going on with potentially people they were not comfortable talking about these things with. And what they found was, rather than preventing PTSD, is that this actually increased PTSD reactions among people. And so even though people thought they were doing something helpful, they were actually doing something that was more harmful. And so while you still occasionally see people touting, critical incident stress debriefing, you should kind of run for the hills when you see that, because it's not actually good. I guess we have this desire to do something. Like, I remember after 9/11, there was a call for psychologists to flood into New York City, but there weren't people necessarily who wanted to talk at that time. It's kind of like a group processing, and you do it at your own pace. If somebody is making you kind of talk before you might be ready, then that can increase your level of trauma. So if you think about, if any of you have ever experienced a bereavement, sometimes, you don't cry right away. It can take a while before, that pain and that real grief hits, and it can be sometimes weeks and even months. So what constitutes a trauma sufficient for a diagnosis of PTSD? So in addition to having direct experience of the traumatic event that could result in one's own death or serious injury, traumas that are included in the DSM-5, the criteria A now, include non-contact sexual abuse, although that's not defined. So that can be like somebody flashing you. Frauderism is technically a contact sex offense, but voyeurism, things like that. Learning of a violent or accidental death of a near or close friend, but not due to natural causes. So, like hearing about your grandmother who died naturally in her bed is not sufficient in order to warrant a diagnosis of PTSD. But if you hear about a loved one who was, killed horribly in a farming accident, for example, that could be sufficient to be, the stimulus for a PTSD reaction. Or repeated or extreme exposure to details of trauma. So one of the terms that we talk about in one of my other classes, the treatment and rehabilitation of offenders, is vicarious trauma. And this has been a phenomenon that's been studied kind of among sex offender therapists in particular. So when you're hearing about these traumatic events that are happening, or people who work with victims, where you constantly hear, or victims of genocide, or victims of war crimes, and you hear about these horrible things over and over again, you can get what's called this vicarious traumatic traumatization. And here, according to the DSM, it's sufficient to constitute a trauma for a diagnosis of PTSD if you have PTSD reaction. So people such as therapists, social workers, judges, or public defenders are susceptible to these kinds of exposures. And among men, military experience is the most common cause of PTSD, and among women, it's rape, sexual, or physical abuse that is most common. So there's a brief variation of PTSD, which ranges from 3 days to 1 month, called acute stress disorder. And that's when you have a lot of the symptoms of PTSD but doesn't meet full diagnostic criteria. People who have acute stress disorder in response to a traumatic event, about 50% of them will go on to have full-blown PTSD. So some people will and some people will not. This is kind of a way for people who are having bad reactions to kind of traumatic events in order to be able to seek services. And for some, it'll resolve on its own, and other people will need to go on and get more intensive services. Excuse me, I'm so sorry. I was trying to pause it, but I could not find the pause button. So PTSD has two subtypes. The first is with dissociative features. So we have depersonalization, so that's the persistent or recurrent feelings of being detached or observing one's own mental processes or bodies as if one was an outside observer. So I kind of use the example of, like when you see on TV people have those out-of-body experiences when they're lying in the emergency department kind of on the stretcher, and then their soul floats into the corner of the room and they watch kind of from outside. So depersonalization is kind of like that. It feels like you're going through the movement, the motions, but it's not actually you. The derealization is the kind of persistent or recurrent feelings of unreality of surroundings. So it's this almost like dream state, like you kind of get the fuzziness at the corners of your vision, and you kind of feel like this is really not happening to me, that this must be a dream or something. PTSD patients who have dissociative features are usually more severe and are at increased risk for suicide. So if you do encounter somebody who has dissociative features, this is a risk factor, again, for more serious and potentially life-threatening behaviors. So it's also delayed when the onset emerges at least 6 months past the trauma, which has a worse prognosis. So this is when the PTSD happens at a later date. So it's not clear why that is. It could be that the people have kind of avoided processing a lot of this information, or there has been kind of this dissociation that's gone on, and therefore the prognosis is not really good. Children can also experience PTSD because obviously children can be exposed to traumas, and so children can receive diagnoses of PTSD when they're very young, but the thresholds are actually lower. So in order to get diagnosed with PTSD from the DSM-5, you have to have trauma, and then you have to have at least 1 month of symptoms. And the intrusion, there are different types of areas, and you have to have kind of different symptoms from different groups. So the first group is the intrusion symptoms. So that's kind of memories or of the traumatic event, so that you're thinking about it. You're having dreams about the traumatic event, flashbacks, which are kind of these like vivid images that kind of pop into your head, or you're kind of experiencing distress or arousal at exposure to internal or external cues that remind you of those traumatic events. So you can see that that criteria is relatively easy to meet, because obviously anybody who's experienced a severe trauma is going to have memories of it, many times experiencing all of the above, like nightmares, flashbacks, thoughts they can't get rid of. There has to also be an avoidance behavior, so that's a behavior where you're kind of avoiding thinking about or getting in contact with things that remind you of the trauma. So you're trying to avoid memories, thoughts, or feelings associated with the traumatic event. So while some people may form support groups, the people who develop PTSD would try to avoid that. They don't want to think about the event. They don't want to speak about the event. They may change their external situation. For example, they may not want to be around people, places, or things that remind them of what happened. For example, returning veterans, they may not want to hang out with their buddies anymore because hanging out with their buddies reminds them of what happened, back in the Middle East. And because those things arouse memories, thoughts, and feelings, so they're trying to avoid all those things. So you have to have one of those. And so new for the DSM-5, you have to have negative alterations in cognitions or mood associated with the traumatic event. So there has to be negative mood states or thoughts that are associated with the negative event. So impaired memory for the traumatic event, so they can't remember important parts of what happened. Persistent, exaggerated negative beliefs about oneself, others, or the world, so that would be kind of along the cognitive way of thinking about depression. Distorted cognitions about the causes and consequences of the event, kind of blaming themselves or other people when, obviously in many cases a lot of these things happen, like car accidents, for example. They're no fault, or they happen because of bad weather. There's nobody to blame. There's a persistent negative emotional state, so feeling, rather than having negative thoughts, this is actually the negative feelings. Diminished interest or participation in activities, again, another symptom of depression. A feeling of detachment from others, so just feeling like you're not connected with other people, and we see that very frequently among returning veterans. So, significant others will often complain that they're not emotionally available to them anymore, and that's kind of one of the symptoms of PTSD. and the persistent inability to feel positive emotions. So a lot of these symptoms describe major depressive disorder, which is obviously comorbid with PTSD, but part and parcel, kind of part of the diagnostic criteria. You also have to have increased arousal or reactivity, and you have to have two of the following: irritability or angry behavior. You'll see that frequently as kind of this lashing out, reckless or self-destructive behavior, and that's kind of quasi-suicidal behavior. So they'll start doing things they wouldn't do before, where there's a possibility of death. So you'll see reckless sex, drug use, things like that, driving quickly, not wearing seatbelts anymore. Hypervigilance, kind of being on guard at all times, like you tap them on the shoulder and they have a very high startle response, which is kind of what you see in the second one. Hypervigilance also is kind of, I had a professor who had served in Vietnam, and he had some symptoms of PTSD, and he would never sit with his back to the door. He always had to be facing the door. He never liked people coming up from behind him. Difficulty concentrating, again, which is associated with both anxiety and depression, and sleep disturbances, which are in part due to the nightmares that people are experiencing. So the prevalence, it's estimated that between 7 and 9% of us will have PTSD in our lives. In a 12-month period, about 3.5% of the population will be diagnosed with PTSD. We see that higher prevalences among trauma-exposed groups like war veterans and rape victims. So just because you've been in war or you've been raped doesn't mean you're going to have PTSD, but about almost up to a third of those who've experienced those events go on to develop PTSD. So that would be, as a clinician, something that you would be assessing if those kinds of events have happened to your clients. PTSD is 3 times more common among women, but men experience more traumatic events overall. So a lot of it is in the interpretation of it. So you probably know that people can experience the same things and have very different outcomes, and a lot of it is how they view it, how they cope with it, and so all of those factors go into play. You also see higher rates among certain racial or ethnic groups, even after adjusting for the traumatic exposure. So such that they controlled, for the level of trauma, but they saw that among Latinos, African Americans, and American Indians, there were higher rates of PTSD. Still, we don't have a very good understanding of why these racial or ethnic differences occur, and what might be causing them. So just to give you a kind of an overview of the prevalence, among police officers, you see it 13%, firefighters 15%, military veterans 30%, raped adults 36%, battered women 45%, and abused children about 50% will go on to develop PTSD. So in terms of the course, the disorder can occur at any age. About 50%, if we think of that brief traumatic stress response, 50% get better within 3 months with or without treatment, but others experience symptoms chronically, although the symptoms may wax and wane. So for example, if they're exposed, like if they have to go back to fight for another tour of duty, or if they're reminded of the trauma in some way, you may see an uptick in the symptom presentation. And the intensity and duration of symptoms are usually less severe if the trauma is caused by natural events than people. I think that's partly because it's easier for us to kind of say, like, this was a freak thing and not to blame anybody, but if, it's a terrorist event, we don't necessarily know when the next thing is going to happen. There's a lot more insecurity, and it's just that people then start having the cognition that the world is an evil place and not safe, which can then be more omnibus and global and then cause more kind of problems for the individual. In terms of comorbidity, about 90% of those with PTSD have a comorbid disorder, so that also goes when we think about kind of what is the disorder. If there's such a high degree of comorbidity, does this mean that this is actually a separate disorder? And what's interesting is about 3/4 of individuals, 77%, also have major depressive diagnosis. And if you think about those negative affective states, if you have multiple of those, those symptoms in and of themselves would meet criteria for MDD, and so you almost have the criteria for major depressive disorder within the criteria for PTSD, so they are highly comorbid. GAD is generalized anxiety disorder. About a little more than a third of individuals with PTSD also have that, and that's just kind of many times feeling that the world is an unsafe place, worrying a lot, and not being able to stop that worry. And we see alcohol use disorders. About a third of people develop some sort of substance use disorders who have PTSD. So how do we assess for PTSD? I mean, the gold standard is the clinician-administered PTSD scale for the DSM-5, the CAPS-5. It's 30 items, so here are some sample items. In the past month, have you had unwanted memories of, and then you insert the event, while you were awake, not counting dreams? How does it happen that you start remembering the event? Are these unwanted memories, or are you thinking about the event on purpose? So this is kind of the intrusive criteria. How much do these memories bother you? So this is how much, it's causing kind of these emotional reactions in you. Are you able to put them out of your mind and think about something else? Those with PTSD cannot do that. These are very intrusive. They feel like they have no control over these thoughts, that these thoughts control them. And how often have you had these memories in the past month? So they have to be happening more often than not in order to receive a diagnosis. There's also a checklist. This is a self-report measure, so obviously clinician-administered assessments are harder to do. They're more time-consuming, so if you're trying to screen large groups of people and identify people who may be at risk for developing PTSD or who have it, you can give a checklist, so the PTSD checklist for the DSM-5. It's 20-item self-reports. Sample item in the past month, how much have you been bothered by repeated disturbing and unwanted memories of stressful events, and then it ranges on a scale of 0 to 4. Obviously, there's no one here to really expand on or further query people's responses, so sometimes you get false positives or false negatives, but again, as a screening kind of tool, it can be helpful. We can also use it in research to look at levels of PTSD symptoms. So if you recall, when we started talking about PTSD, we now said it was related to other stress-related disorders that kind of happen in response to these negative events. So other stress-related disorders that kind of fall into those categories, and some of you might be doing your presentations on this, are reactive attachment disorder of infancy. So this is when children cannot be separated from their parents, and this is more than just separation anxiety, that they have these tremendous negative reactions when they are separated from their parents. Disinhibited social engagement disorder, the acute stress disorder that we talked about, and then adjustment disorder. So an adjustment disorder used to be a separate category in the DSM-4, and now it's kind of put with these other related stress disorders. So this was kind of I don't want to say garbage diagnosis, but anybody that was having some sort of psychological problems but did not meet diagnostic criteria would be given a diagnosis of adjustment disorder for insurance purposes so they can get reimbursed. And so it was very commonly seen for people with anxiety and depressive disorders who were kind of sub-threshold. So something happened, you don't meet diagnostic criteria, but you do need treatment because it's impacting the quality of your life. And so here it's now moved with this other stress-related disorders, and you see that similar to what I just described, it has to be in response to a stressor, it has to last 6 months or less, and include depressed or anxious mood and disturbance of behavior. So in terms of differential diagnosis, things that you want to consider, PTSD may go undiagnosed because patients don't report the initial trauma or subsequent symptoms. So, for example, if people have difficulty remembering, or if they're choosing to avoid thinking about the trauma, they may not report what happened to them, and obviously in order to have PTSD you have to be exposed to a trauma as was described in criterion A. People's substance abuse becomes so severe that it masks the symptoms. People self-medicate oftentimes when they have PTSD. The traumatic imagery can be misattributed, especially if they have derealization and depersonalization, to schizophrenia, LSD intoxication, epilepsy, or dissociative disorder. It can be attributed to past psychiatric disorders, so we see this among patients, especially those who have psychotic disorders, who don't have a lot of people looking out for them. They may have their existing symptoms, but then they may experience trauma, from living out in the street or from other things that go on in their lives, and it's kind of masked by some of their other psychological symptoms, or it's minimized by clinicians because they have this diagnosis to begin with. And the patient may no longer be able to distinguish reality from fabrication, and so people then might think that they are malingering and they won't take their symptoms seriously. So in terms of etiology, about 60% of men and 50% of women will experience a trauma in their lifetime. I think the higher prevalence among men is because it's still, men have a tendency more to go into battle, although obviously that's changing, and probably as that changes more and more, we'll see higher rates among women. However, the majority of them will not develop PTSD. So risk factors for PTSD include the severity and duration of the trauma, so what you actually witnessed, prior exposure to trauma or adversity. So it might be that you can handle a certain amount, but then this last thing kind of puts you over the edge, kind of like the kindling hypothesis, like you can take so much, but then once that barrier is broken, then the symptoms kind of ensue. Somebody has pre-existing psychopathology, such as depression or anxiety, their threshold may be lowered as well, and they may be more susceptible to PTSD. Social, educational, and intellectual disadvantage, so those that are of higher educational level and higher intellectual ability might be less likely to experience PTSD. It also might be that those individuals are more likely to seek help, and therefore they can prevent the disorder from happening. There's those with limited structural or functional support may develop PTSD. Being female and being younger also contribute to developing PTSD. Biological systems are also indicated in the pathophysiology of PTSD. In the HPA axis, dysfunction, serotonergic system, amygdala disinhibition, and prefrontal cortex. So you're seeing it in a lot of different areas of the brain. It's not specified yet, but we do see that the presentation is different from other anxiety disorders, and hence why it's been kind of put off as a separate one. In terms of models of PTSD, they must explain the intrusion, the constriction, and behavior emotions, and the hyperarousal. So in terms of the CBT models, there's the two-factor model, which we talked about with anxiety, that was developed by Maurer. So the unconditional stimulus becomes paired with other stimuli, so we get a conditional emotional response to stimuli other than the trauma. So the trauma becomes paired with people, places, or things. You then avoid those things to reduce the negative emotions, which then maintains the negative emotions and to the conditioned and unconditional stimuli. So you experience the trauma becomes paired with something else. You then avoid those things that are related to the trauma. By avoiding, you then don't experience, and then you're avoiding those symptoms. And as we know from exposure therapy, that exposure is necessary to kind of minimize some of those things. Edna Foa, who is kind of the champion, the woman who does the most research into the treatment of PTSD, she's located at Penn. She developed the information processing model of fear networks. So the pathological fear structures develop after traumatic events that include fear stimuli, response, meaning, and then when activated, these fear networks result in cognitive, behavioral, and arousal symptoms. In terms of management and treatment of PTSD, cognitive behavioral therapy is kind of the treatment of choice. It's where you have exposure, so that's the activation of the fear network, according to Foa. You can either do this by having them retell what happened over and over again, imagining it. You can do it imaginal or in vivo, where they actually re-experience the trauma, so you might have video, or they now do virtual reality exposure, so they're doing that with war veterans, and they've had very good results with it. Some of the VAs are really at the cutting edge of some of the PTSD research, so if that's something that you're interested in, I would look into some of the VAs. The Boston VA in particular has a really good research group that's doing research into PTSD. You're also learning new information, so you're teaching people how to tolerate anxiety, to help them discriminate between true dangers and false alarms. So it's kind of, when you think about like what we talked about with the panic disorder, we teach people how to then re-evaluate their cognitions and their emotional and physiological experiences so that they're not as traumatic. Disconfirming beliefs, John F. Bullman's fundamental assumptions, the world is benevolent, meaningful, and self is worthy. So it's kind of like changing from the world is a dangerous place to kind of feeling like there is good and worth in the world. We've also seen positive outcomes with EMDR, eye movement desensitization or reprocessing therapy, but there's a lot of controversy. It's basically called a sham therapy because the eye movements are not what causes the diminution of trauma, but rather the exposure to traumatic events. So in EMDR, you have people talk about the trauma while moving their eyes back and forth, and so they see with this treatment that the trauma diminishes, but basically in dismantling studies where they look at the different parts, it's not the eye movement per se that that makes the difference. It's really the exposure or the talking about what's happened to them. The eye movements become distracting, so it's more palpable for individuals. It feels less stressful for them to focus on that, but given that people have to pay hundreds and thousands of dollars to receive training in EMDR when it's not really EMDR that works is kind of unethical. You can also medicate with SSRIs, Zoloft and Paxil, although that's not a long-term solution. I mean, it can help, get people through the rough times, but ideally, exposure therapy is what needs to be done in order to diminish the symptoms. So you'll see that the blue is people who experience prolonged exposure therapy, and these are their symptoms pre, post, and 12 months following therapy, and the most significant change is seen among those who participated in the exposure as opposed to the waitlist controls. So you'll see even with time the waitlist controls go down, but that the most change is seen with those who engage in prolonged exposure. We talked about critical incident stress debriefing. A lot of it depends on the individual. So you can have, there is some evidence that debriefing, but not this forced debriefing, can be helpful, but it's only if the person feels comfortable. So disclosing the events, exploration of troubled reactions, identifying practical coping strategies, and exploration of feelings about leaving. Again, this can't be forced on people, which is being done in critical incident stress debriefing. So again, this is something that is somewhat controversial. I wouldn't necessarily encourage this. I think these are things that people can do as they are ready. People who've witnessed traumatic events need to deal with them in their own time and space. Having good support groups is very important. As we said, it's a risk factor. And PTSD may remit spontaneously, but those the chronic and more severe cases where you have more than 5 months of symptoms, you may require more intensive psychotherapy and prolonged